Hi, my name is Jay Huang. I'm a junior attending pathologist in the United States, and I go over cases almost on the daily from head to toe. If you're interested in that, consider giving a like and subscribe. Without further ado, thank you to Pathlibrary for these online cases and annotations. So this is an inguinal lymph node, and as you can see here, there is no primary and secondary follicles. What we see instead is effacement of the lymph node, normal lymph node architecture. We have this kind of cloudy-like appearance. And so just, if I had to guess, this is chronic lymphocytic leukemia lymphoma, or small lymphocytic leukemia lymphoma, CLL, SLL. And the way I understand how to divide these different lymphomas, like mantle cell, BALL, Burkitt's, hairy cell leukemia, one of my co-residents at the time told me about this mnemonic. So cold man, so C and M stand for CLL, SLL, and man for mantle, and it's cold because these stand for CD5 and they're CD10 negative. And so this CLL, SLL should be CD5 positive. And to distinguish it from mantle cell, well, what do you hang on the mantle? You hang socks, right, during Christmas time. And so mantle cell will be SOX 11 positive. CLL, SLL will also have CD21 positivity. And then just kind of, you have the cold man. And then you have like, the way I see it is like dung beetles bury follicular shaped balls. So dung stands for like DLBCL, although they can be seen in, they can have various expression patterns of CD5 and 10. But I say they're in that mnemonic, it's CD10 positive. They bury, so bury for Burkitt's, follicular shaped for follicular lymphoma, dung balls for BALL, and then for CD5, CD10 negative, I think of the Simpsons characters. So H, Homer, for hairy cell leukemia, Lisa for lymphoplasmacytic lymphoma, leukemia, and Marge for marginal zone lymphoma, leukemia, or marginal zone lymphoma, excuse me. So let's go here. So the hallmark of CLL, SLL is you'll have these proliferation centers, right? And these are mainly seen in adult patients. And you can't really make the diagnosis just on histo. So yeah, this is a 70-year-old male, and it should be CD5 positive. CD3, I mean, just maybe some background T cell. CD20, yes, because this is a B cell neoplasm. CD5, yep, diffusely positive. It's important to know that CD5 also stains T cells. So those small T cells should also stain with CD5, and that's not abnormal. CD23 or 21 should be positive. CD10, patchy non-specific staining, so it's not diffusely staining. CD30 highlights occasional scatter immunoblasts. CD21, occasional FDC meshwork remnants. BCL6 negative, cyclin D1 negative, SOX 11 negative, that'd be positive in mantle. Or yeah, mantle. Cyclin D1 would also be positive in mantle. 11-14 translocation. Key 67, 5%, not too diffuse. PAX5 diffusely positive because this is a B cell neoplasm. BCL2 is diffusely positive. Okay, so this diagnosis classically shows a cloudy, low power appearance, and it's CLL, SLL. So this is a morphologically classic case of CLL, SLL. The lymph node architecture is completely effaced. No discrete lymphoid follicles remain. Architecture is replaced with a cloudy appearance, in which vaguely nodular, paler proliferation centers are superimposed on a slightly darker background. Compared to background lymphocytes, the nuclei are approximately the same size, making this a small-sized lymphoma. Proliferation centers are populated by pro-lymphocytes, with round nuclei and a single prominent nucleolus, as we can see here. Other nuclei with speckled or clumped chromatin have been likened to soccer balls. Diffuse positivity for PAX5 and or CD20 can be used to confirm that this is a small B-cell lymphoma, and diffuse positivity for CD5 and CD23 confirms the diagnosis of CLL/SLL. Your differential diagnosis, follicular lymphoma shows anastomosing or enlarged germinal centers lacking tingible body macrophages. It's positive for CD10 and BCL6. Mantle cell lymphoma, it shows implosion of mantle cell zone cells into germinal centers. Nuclei have irregular contour, cyclin D1 and SOX11 positive, CD23 negative. Please pardon me, earlier I said CLL/SLL should have CD21 positive. I meant CD23 positive. And that will be negative, as we see here in mantle cell lymphoma. Marginal zone lymphoma, this is MARG for Simpson, so this is CD5, CD10 negative, shows an irregular nodular architecture at low power. It's very monocytoid and can have a plasmacytoid morphology too. What monocytoid means basically is it has a clear halo cytoplasm around their nuclei. It's negative for CD5 and CD23, maybe positive for CD43. And here's a close-up view of marginal zone. Lymphoplasmacytic lymphoma, LPL, is characterized by plasmacytoid morphology. You'll have Dutcher bodies or Russell bodies are classically seen, which are round eosinophilic aggregates of immunoglobulin. They're constipated, so to speak, plasma cells. They are termed Dutcher bodies if they indent or overlap the nucleus, as we can see here, and Russell bodies if they are located in the cytoplasm. The majority of patients with nodal involvement of LPL have known monoclonal gammopathy at the time of biopsy, which you can tell by doing a serum protein electrophoresis, SPEP. And mutation testing for MyD88, the characteristic mutation in LPL, can be performed if suspicion is high. Let's look at practice questions. So describe Richter transformation. So that is when your CLL/SLL or other low-grade neoplasms transform into DLBCL. So it's a high-grade transformation of CLL/SLL into either DLBCL or Hodgkin's lymphoma. This change is the result of mutations of TP53 and CDKN2A, or less commonly mutations of Notch1 with trisomy 12. Patients commonly present with the appearance of B symptoms and suddenly enlarging lymph nodes. Histologically, Richter transformation is characterized by a confluent growth of large atypical cells. Name the 5 small B-cell lymphomas. Follicular, CLL/SLL, marginal. We'll see. Let's see. CLL/SLL, follicular, mantle, marginal zone, and lymphoplasmacytic lymphoma. And discussion, CLL/SLL is an indolent small B-cell lymphoma that usually affects older adults. It has a complex karyotype without specific translocations. High-grade transformation occurs in approximately 5% of cases, so something to keep in the back of our heads. And again, just low power, you'll see a cloudy appearance. High power, the ones that have stippled chromatin will have a soccer ball-like appearance. It's positive for CD5, CD23. Mantle cell is also positive for CD5, but that will be CD23 negative, cyclin D1 positive, and SOX11 positive. Well, that's all for today. Thank you again for Pathlibrary for this online case and great teaching points. I'll see y'all next time. Bye.